best way to do an assessment is on skin. So you guys, whenever you are listening to a patient's lungs, you have to put your stethoscope directly on the patient's skin. Now tell me why.
Because you can get movement from clothes and things.
Yes, exactly. So whenever you are listening to the lungs, think about what the stethoscope is designed for, right? You're supposed to create that suction with the diaphragm of the stethoscope and the skin, the patient of the skin. So when the chest wall expands, it just focuses on the sound inside, right? On the lung sound. You're listening on top, and if you've got a couple of layers of clothing, then that's gonna rub as the chest wall expands, creating artificial sounds, interference. And so you will say to me, well, I see doctors or nurses listen all the time. Sure, it's not the best practice, but most importantly, they have been listening to the lungs for maybe 10 years or more or whatever, and they have learned to distinguish the lung sound versus interference. You guys do not have that skill yet. So you need to be really listening on skin and learning what a lung sound really sounds like, okay? So what a healthy lung sounds. And then when you are listening 10 years down the road and you feel like you can't take the shirt off or the patient doesn't want to, and you're listening over somebody's clothing, you at least know what you're listening for and knowing how to distinguish those sounds. So always think like you're in the beginning stages of your nursing career. So you can't quite do some shortcuts that maybe you see other nurses, experienced nurses doing, because you don't know enough to make those shortcuts for yourself yet. So I'm not teaching you any shortcuts. I am teaching you standard of practice, ideal situations, so you can have that skill, okay? And so if you think about your patient, we talked about yesterday, anterior chest and posterior, right? So if you think about the lungs, they're kind of sort of occupying your chest wall, right? Thoracic cavity. They're not necessarily suspended there, right? But they're also spread out. It's not like the heart that's just on the side. It's more of like lobes of lungs. Like I just think about like blobs of lungs that are kind of hanging. And so you think about it, if it's kind of like this, you want to be able to assess and listen to it from different sides, right? That's why we're listening in the front, and then we're listening in the back as well. So we already observed our patient, and then also I'm visually looking at her, and what I'm interested to kind of identify is where my patient's diaphragm, right? So the stomach is right here approximately, does that make sense? And the diaphragm sits above that, right? So when I take a deep breath, my diaphragm maybe moves down to here, but not down here. And so when I'm thinking about listening to somebody's lung sounds, my primary focus will be upper chest, right? Especially with women with breast tissue, it's really difficult to listen and hear a lung. You can listen all day long, but to hear something meaningful is going to be a lot harder if you try to listen through the breast tissue. So you might have to kind of think about that when you're assessing a patient. So traditionally, we think about we talked about anatomy yesterday. So trachea, right? And then the lungs kind of come up a little bit. And so when you expand, you can hear the lung sounds and around your trachea here, and then starting up here. So I am going to create my kind of map for a patient of where I'm going to listen based on what I know about the anatomy, right? This diagram, and you can use that if you like. I honestly can tell you that this is a good way to learn a comprehensive assessment. Rarely in reality do I listen to 9, 10, 12, and 11 and 12. Just because the sound can resonate, right? When I take a deep breath, you can pick up the sounds. But it's just a lot harder for me because I'm also listening to the vowel tones at that point, and then distinguishing the two is something's gonna take you a little bit of time. Also, if I ask you to take 12 deep breaths kind of in a row, you're gonna be like, that's a little hard for me. So now think about your patient who may have asthma or obstructive pulmonary disease. That's gonna be even harder for them, right? So always give your patient an opportunity to break and take a, like rest a little bit, and tell them like, if it gets a little bit harder, let me know and we can do something else, and then we'll finish the assessment. Remember, we are learning at like one piece right now, but in reality, if your patient needed a break, you can stop and listen to their stomach or their heart, or you can check their strength, muscle strength at that time. Always something to do with the patient. Okay, also notice that on the diagram, they're showing you to go from one side to another. Why is that important?
You can hear the difference in the same location.
Exactly, you're able to compare because you may have a problem on the right side but not the left, or you may have some fine crackles or fine wheezing on one side and not the other. And if you just go on one side and then go to the other, you may or may not remember where and what exactly you heard. So always side to side comparison. I brought my stethoscope and I put it down somewhere, so give me just a second. What you want to do is put your stethoscope and you start, and I'm not gonna undress her, but know that when you're pulling the curtain and practicing with each other, give yourself as much opportunity to listen on skin. I don't wanna embarrass anybody, I don't wanna violate your privacy, any of those things. If you're comfortable with the front, great. If you're front, whatever you're comfortable with, just know that that's really the best way to listen. And so the other thing you have to remember to do is you ask your patient to take a deep breath in and out, and you are listening with the stethoscope for the entire duration of the inspiration and expiration. So I'm gonna start here because it's easy for you to see. Normally I would start here. So go ahead and take a deep breath in and out. And out. And so I am listening for the entire cycle. Now tell me why it's important to listen for the entire cycle.
So you can hear the airspeed.
Why is that important?
I mean, I'm not.
You're on the right, you are totally right.
Maybe for like how long it took for them to exhale and inhale.
So the
Like to hear wheezing and stuff like that when they
absolutely right. So two things you mentioned, and you're absolutely correct on both. Depending on where you listen, your inspiration may be shorter or longer than expiration. So that is important as well. And knowing when is what is important, because if you find an abnormal pattern, then you know there's some kind of abnormality with the patient, right? The second piece, you're also important as well. Some people will have wheezing here, like you think about stridor, think about asthma, right? And some people, patients like who have chronic obstructive pulmonary disease, will have crackles, but on the expiration. So if you only listen when she took a deep breath and moved on, you are going to miss that whole piece. We talked about atelectasis yesterday, how air gets trapped in the lower parts of the lungs, right? And so that is often something we pick up on the expiratory. So the entire cycle. You can also tell your patient, take a breath in and out every time I move my stethoscope, and you wait until they completely exhaled to move your stethoscope to another spot. Does that make sense to you guys? Okay, so we listen on the front, and so I'm gonna have you stand up for us. And can you take this top off? Okay, slowly delayering. Okay, and so I'm going to show you where I listen, just the placement of the stethoscope. I will go, like, no, you know, I could sneak my stethoscope right here, but then you're not going to be able to see where I put it. So I am going to start here, but then I'm going to move over her shirt. Not because it's the best practice, but because I want you to see the placement. And so take a breath and take a breath every time you touch the chest with the stethoscope. And now you can breathe normally. I'm gonna go over her shirt and I would listen here and here as well. And so if you're trying to do here, you could, but I honestly feel it doesn't add much value to your assessment. Do you need to know how to do it in case you're in a situation where you need to? Yes, realistically, it's probably not the best place to listen. And also your patient is gonna get tired, so I'm gonna listen where I am going to benefit the most from it. Okay, so we talked yesterday about the anatomy of the lungs. So where did we decide yesterday?
2 and 3.
2 and 3, okay. So, right side, I'm a terrible artist, so I sincerely apologize. All right, so this is my attempt at illustration, the anatomy of the right lung. And what I'm trying to have you guys visualize is that when it comes to the right lung, because there are 3, you know, it branches differently than it does on the left side. And so on the left side, it's kind of just like this and then up. On the right side, because there are 3, the upper lobe turns upward a little bit at the branch, and then the middle lobe is kind of anatomically just kind of a continuation of the trachea. And then the lower lobe is kind of tucked in a little bit.
The left is smaller.
I mean right, I'm sorry.
The left is smaller.
A little bit. But that's not the, it's not as much right now. What I want you to guys think about is how the air flows when you inhale. So does it make sense that this is the path of least resistance? So this is right middle lobe. So now I have trouble swallowing and my food goes into my lungs. Where is that gonna end up?
Right upper.
Right.
Oh,
Right middle lobe, right? So when somebody says patient has aspiration pneumonia, you know that it's because gastric content, right, ended up where it's not supposed to be. Most likely, it ended up in the right middle lobe. So if you have a patient with aspiration pneumonia, where are you going to listen?
Right middle.
Right side, and more specifically,
Middle.
middle of where?
6 and 7. We were just going by the diagram.
Oh.
Sorry.
So,
8, you said? Yeah.
so, but this is anterior, right?
Oh.
So where are we gonna listen? Remember, we are not one-dimensional.
How about 9 and 12?
Posterior.
Don't look at
Oh,
the,
sorry.
don't look at the diagram, look at the patient.
Oh, the patient.
Don't look at the
No, look
diagram,
there,
look
okay.
at the patient. Like, tell me, Lara, on you or Berzaf, you can find it,
On the right, back, posterior.
okay, so you're right, like right here somewhere, right? So this is where you would listen to it, okay? So when we talk about lung assessment, right, then the desire is sort of listen front and back because we talked about anterior and posterior. But the lungs, as we said, is kind of tubular or lobular, and they kind of are just there. And so right middle lobe tends to be best heard under the arm. And remember, the diaphragm runs about this way, right? We decided. So you would be listening in this area here. Does that make sense? And you understand why, right? Okay. Yes, yeah. And so I think I have it, I don't know. No. Okay, posterior chair, okay. So on my patient, I would figure out where the right and the left is. So this is her left side, this is her right side. I would have her give herself a hug, and then I would place my stethoscope in like maybe 3 or 4 spots, and they will be, remember we said the diaphragm is right here, right? So it will be anywhere above where my hand is. Yes? Okay, does it make sense to all of you? All right, then we're gonna move on to the posterior chest. You can rest. Do the same that we did in the front. Side, just by side comparison, and all the way down. So if you think about, again, where the diaphragm is, right? No need to listen down here. I know sometimes diaphragm just like, and here it looks like they're like at the waistline. Some sounds will resonate and you will be able to pick up some sounds, but it really isn't the ideal place to listen anymore. And so what I'm thinking is a letter J. It goes down, 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 and then goes this way. And remember, my lung kind of is smaller here because I have other structures and because the chest is wider here, right? So I kind of do a letter J. And then down here, and then letter J in the mirror goes this way. So if I listen here, that's her spine, right? I'm not gonna hear lung sound. So we have the spine, we have the spinal column. There are like ligaments and tendons and there's bones. So that kind of goes like about there. Listening over it is not gonna help me because I'm not catching the right lung or the left one, and I don't know what I'm listening to really. I may be hearing something very quietly because it's coming through, right? But it's not ideal. So I'm going to find her scapula, and then I'm going to find her spine. And so this column in the middle is what I'm going to follow. And so I will do the same thing. I'll ask my patient, take a breath every time I move my stethoscope. And then I'm gonna go from here to here. And down here. And one more time. Questions? let me erase this before you start taking pictures. Too late. So if I put my hand here, yes, and then I turn her this way, it would take two hands, right? So that's anterior to posterior diameter, and I have 1 to 2, right? Does that make sense? AP diameter. I can also check for lung expansion. I'll put my fingers together and then take a deep breath for me. Do you see how my fingers come apart? And they're doing it symmetrically. Thank you. So if she had a collapsed lung on one side, it wouldn't come the same way, right? Does it make sense? It would be asymmetrical. There would be no symmetry there. So those are the tests that you can guys do with your patient. I'm also looking at her spine, and the reason I'm doing that is because I want to see if it's straight. If she had scoliosis or kyphosis or lordosis, it means, hang on a second. Let's say the S, right, shape. So think about this spine, but this portion of it is shifted to the left or the right. So the whole thing just comes this way. So think about my lung in here and what's happening to my lung on this side if the spine is all the way here. It's getting squished. If my lung is getting squished, what does that put me at risk for?
You're gonna get an abnormal
Breathing.
Your breathing
You're
is
breathing
off.
off. Yeah.
Okay, so what's the problem with my breathing being a little off? Potentially.
You're not getting as much
Oxygen.
Not getting as much oxygen. What else is it difficult? Remember we said that lungs are kind of globular, and when the air comes in, they expand, right? So if there is physically something blocking that lung, is that going to be easy to expand? All right. We also said if we can't fully expand the lung, then air gets trapped in there, right? So if air gets trapped in there, what am I at risk for here?
Infection.
Water trapping, like moisture trapping, air trapping, and that leads to
Infection.
Yeah.
It's
Yeah, right? Do you guys remember that the air that we breathe in does have bacteria? And if we just trap it in there and the air isn't able to escape, then this patient is at risk for a respiratory infection. Same is true for your patient with chronic obstructive pulmonary disease or the patient who is not moving after surgery because they're not expanding their lungs, they're not using their full lung capacity, and therefore they're trapping some air that can lead to the development of infection. Does that make sense? That applies to your post-surgical patient, it applies to your immobile patient, it applies to your patient with scoliosis, or whatever the issue may be that leads to decreased mobility, and then that decreased mobility leads to decreased lung exchange, air exchange, and that always leads to pneumonia. And so the sad story, well, there's so many, but anyway, like, you know, in the past, and you guys are not old enough to know that, but when people used to have heart attacks and survive heart attacks, we used to put them on bed rest for like a month because we didn't want to put any additional stress on them. And so my grandma had a heart attack and survived, but they kept her in bed. So 2 months later, she died from the complications from pneumonia because she was just sitting in bed and doing nothing. And so like anything that happens with the body that leads to this prolonged immobility will lead to respiratory complications as well. Does that make sense to you? Okay. All right. Questions? No?
So patient has to keep moving all the time, like after surgery and whatnot.
Well, so
Is that why they want them to keep like walking, moving?
It's so define keep moving.
Like just walking, not staying in bed, pretty much.
All right.
After surgery.
Cannot get out of bed.
One more time.
Use the spirometer
Oh, yeah. Oh, look at you, so stupid.
to exercise the lungs.
Yeah. Oh, that's kind of.
So this, I have mouthpieces for it, so you guys can practice with this with new mouthpieces. But basically the goal, it's not as easy as it looks, I just tell you that. The little bubble needs to be kept up here. So it can go up and down and it needs to be steady. And then you set the goals for your patient, lower in the beginning. And so you think you have to blow in it, but it's actually not. You breathe in.